Hey, future doctors. Welcome back to the deep dive.
That's right, we're back.
We know you're all working super hard getting ready for the MCCQE.
And we are here to help.
I'm so excited for this deep dive.
Me too.
I think this is going to be a good one.
It is.
So let's get started.
Okay.
We're going to be your guides to help you navigate these high-yield concepts.
Think of us like your study buddies.
Yeah.
But like the really cool ones.
Exactly.
The ones that you actually want to hang out with.
That's us.
Okay, so
We're going to break down all the major topics that you'll need to know for the exam, and we're going to use evidence-based resources like stat pearls to help
we will.
make sure you're feeling confident and ready for the real deal.
That's right. And,
Okay, so before we get started,
yeah,
super important disclaimer.
always.
This is not medical advice.
Never.
We are not doctors.
We are not.
We are just here to help you understand the material.
Exactly.
But for real-life health concerns, you should always consult a qualified healthcare provider. Okay, so with that out of the way,
Yes.
let's jump in.
Let's do it.
So.
So today we are diving into
Yeah.
a topic that is pretty much guaranteed to show up on the MCCQE.
It is.
Valvular heart disease.
Yes.
Yes.
Valvular heart disease.
Let's get into it.
Think about the heart like a finely tuned machine
Okay.
with 4 valves that act like these little gatekeepers
They do.
to make sure that blood is flowing in the right direction.
That's right. We've got the aortic valve, the mitral valve, the tricuspid valve,
Yes.
and the pulmonary valve.
Yes.
Those are our 4 valves of the heart.
But like any machine that's, used all the time, things can go wrong.
Things can go wrong, and they do go wrong.
And they do.
So when it comes to our heart valves,
Yes.
there are 2 main ways that they can malfunction.
Stenosis and regurgitation.
Yes, stenosis and regurgitation.
Stenosis is basically like having a clogged pipe,
It is.
narrowing the valve and restricting that blood flow.
Regurgitation, on the other hand, is like having a leaky faucet,
I like that analogy.
allowing blood to flow backward
Backward.
when it shouldn't be.
That's right. So.
And to make things even more interesting, either of these problems can occur in any of the 4 valves, leading to
A whole bunch of different presentations.
a spectrum, yes, of different presentations.
So many things to keep track of.
So many.
Okay, but for the MCCQE, let's focus on
Yes.
the big ones.
Heavy hitters.
The ones that we're most likely to encounter.
Aortic and mitral valves.
Yes. Those are the ones that are most likely to show up on the exam.
Absolutely.
So let's start with
Let's start with aortic stenosis.
aortic stenosis. Okay.
Aortic stenosis.
So if I remember correctly, this one presents with a classic triad of symptoms.
Yes, it does.
What is that triad?
Chest pain, syncope, and shortness of breath.
Yes. Chest pain, shortness of breath, and syncope.
Your red flags.
Yeah. Red flags.
You do not want to miss.
You not miss these.
And if we think back to the pathophysiology, it all comes down to that narrowed aortic valve creating a bottleneck.
Yes, a bottleneck for that blood flow.
Exactly. So the left ventricle, which is, the powerhouse of the heart pumping blood out to the body,
It is.
has to work overtime to push blood through that narrowed opening.
So much extra work.
So much extra work.
And over time, that extra workload puts a strain on the left ventricle.
It does.
Causes it to thicken and eventually can lead to heart failure.
And eventually it can lead to heart failure.
Yes.
Yeah.
What are some things that we might see on exam or...
Yeah, here's a detail that might help
That-
solidify your understanding.
Okay.
Imagine you are examining a patient
Okay.
and you feel their carotid pulse and it's weak
Okay.
and delayed. That's called pulsus parvus et tardus.
Pulsus parvus et tardus.
Pulsus parvus et tardus.
That's a mouthful.
It is.
But it's important. It's a very important detail.
So a weak carotid pulse
Yes.
could be a sign that we're dealing with a severe case of aortic stenosis.
Absolutely.
Okay. It's these little connections that can really make a difference
They can
on the MCCQE.
set you apart from
Set you apart, yes.
the other test takers. Another interesting finding is the Gallivarden phenomenon.
The Gallivarden phenomenon.
Have you heard of that one?
I have not.
Okay, so the Gallivarden phenomenon
Yeah.
is where high-frequency components of the murmur radiate to the apex of the heart.
Okay.
Think of it like ripples spreading out from a stone dropped in the water.
Okay, so even though the problem is at the aortic valve,
Yes.
we might hear these murmur sounds radiating to a different part of the heart.
Precisely.
Wow.
And that's why understanding those nuances of auscultation
Yes.
is so, so important.
So important.
Now, when it comes to diagnosing and staging aortic stenosis, our best friend is going to be Echocardiography.
Echocardiography.
The echo.
Our window into the heart.
It lets us see the valve in action and assess how bad the narrowing is.
Exactly.
So once we have a clear picture of what's going on, we can think about treatment. What are our options?
So, for mild cases, watchful waiting and lifestyle modifications might be enough.
Sorry.
But in severe cases, the gold standard is aortic valve replacement, or AVR.
AVR makes sense.
Makes sense.
And I remember there are two main types of AVR.
Two main types.
Surgical AVR
Yes.
or SAVR, which is that traditional open heart surgery.
Yeah.
And then we have the less invasive transcatheter AVR.
TAVR.
Or TAVR.
Yes.
So TAVR.
Involves inserting a new valve through a catheter, usually in the groin.
The groin. Yeah.
Yes.
Okay.
It was initially reserved for high-risk patients who couldn't tolerate open heart surgery, but it's become a much more viable option for a wider range of people these days.
It's amazing how technology is changing the way we approach these conditions.
It's amazing, isn't it?
It is.
Okay, so now that we've talked about aortic stenosis,
Yeah.
let's switch gears and talk about aortic regurgitation,
Aortic regurgitation.
also known as aortic insufficiency.
Okay.
This one is all about backflow.
Backflow.
Yeah.
So instead of the valve being too narrow like we saw with stenosis, it's not closing properly,
Yes.
allowing blood to leak back into the left ventricle.
That's right.
Okay.
And that backflow, just like with stenosis, creates a volume overload on the left ventricle.
So both stenosis and regurgitation,
Yes.
the left ventricle is having to work harder,
Work harder,
but for different reasons.
but for different reasons, exactly.
Okay.
And over time, that extra workload can lead to left ventricular dilation and eventually heart failure.
Heart failure is bad.
Heart failure is bad.
We want to try to prevent heart failure as much as possible.
Yes, we do.
So,
Now, here's where things get interesting.
okay, ready.
With aortic regurgitation,
Oh.
the presentation
Yeah.
can vary so much depending on whether it's acute or chronic.
Okay, so what's the difference between acute and chronic aortic regurgitation?
Okay, so acute aortic regurgitation is like a sudden plumbing emergency.
A plumbing emergency.
The valve just fails dramatically,
Uh-huh.
leading to a rapid onset of heart failure symptom,
Rapid onset.
potentially even cardiogenic shock.
Yikes.
Yeah,
Okay, that sounds really bad.
it can be very bad.
So what about chronic aortic regurgitation?
Chronic cases are more like a slow leak.
A slow leak.
Yeah, symptoms develop gradually,
Gradually.
and you might see things like exertional dyspnea,
Exertional dyspnea.
which is shortness of breath with activity,
Okay.
orthopnea,
Orthopnea.
which is difficulty breathing when lying flat,
Interesting.
and palpitations.
Okay, so very different presentation,
Very different presentation.
depending on if it's acute or chronic.
Now, chronic aortic regurgitation also has some unique physical exam findings
Okay, tell me about these.
that can really help you clinch the diagnosis.
I'm ready.
Have you ever heard of the Corrigan pulse?
The Corrigan pulse. I feel like I've come across that in my studies, but I need a refresher.
Okay, so the Corrigan pulse is a bounding, forceful pulse that you can feel in the patient's arteries. It's caused by the rapid ejection of a large volume of blood from that left ventricle.
So it's like the pulse is exaggerated because of that backflow?
Exactly, because of all that volume.
Okay.
And then there's the de Musset sign.
The de Musset sign?
De Musset sign.
That one rings a bell. It's the head bobbing, right?
It is the head bobbing.
Head bobbing.
So imagine you see a patient and their head is subtly bobbing with each heartbeat.
I'm picturing it now.
It might seem strange,
It does.
but it's a classic sign.
Okay, the head bobbing.
Head bobbing.
That's one I'll remember.
Good.
Are there any other kind of unusual signs that we might see with aortic regurgitation?
Yes, there are. We also have the Quincke sign,
The quick time?
which is visible pulsations in the fingernails,
Wow.
and the Muller sign,
The Muller sign.
which involves pulsations of the uvula.
The uvula.
Yes.
Wow, so many interesting signs.
I know, it's amazing.
Okay, so these signs might seem subtle, but they can really point us towards the underlying problem.
They are little clues.
Little clues.
Okay, so now let's talk about how we manage aortic regurgitation.
Okay, I'm ready.
So for mild cases, medical management with medications like ACE inhibitors or ARBs to control blood pressure might be enough.
Okay.
But for more severe cases,
I'm guessing we need to intervene a little bit more
we do.
aggressively.
Yes, for severe aortic regurgitation, the definitive treatment is surgical intervention with aortic valve replacement, similar to what we talked about with aortic stenosis.
Okay, so
Yeah.
AVR
AVR.
is our go-to for both stenosis and severe regurgitation of the aortic valve.
It is.
Okay.
Now, are you ready to move on to the mitral valve?
Absolutely. Bring on the mitral valve.
Okay, so let's dive into the world of the mitral valve, starting with mitral stenosis. This one has a bit of a global health twist, as it's often linked to rheumatic fever, which is more common in developing countries.
Oh, that's a good point, that these conditions aren't limited by geography. So with mitral stenosis, we're dealing with a narrowed mitral valve, which means blood flow from the left atrium to the ventricle is obstructed. What kind of domino effect does that create?
Well, imagine a traffic jam at the entrance to a major highway. That backup can cause congestion for miles. Similarly, in mitral stenosis, the left atrium, which receives blood from the lungs, has to work harder to push blood through that narrowed valve.
Right, and that extra pressure can back up into the lungs, leading to pulmonary hypertension, which is high blood pressure in the pulmonary arteries.
Exactly, and if left untreated, it can even lead to right-sided heart failure, as the right side of the heart struggles to pump blood against that increased pressure in the lungs.
Wow, so it really is a chain reaction that can affect the entire heart.
Now, just like with aortic stenosis, there are some specific sounds that can clue us into the presence of mitral stenosis.
Okay, tell me more about these auditory clues. What should we be listening for?
When listening to the heart with a stethoscope, you'll hear a loud S1 heart sound followed by an opening snap, which is a sharp, high-pitched sound that occurs as the narrowed mitral valve opens, and then there's a low-pitched diastolic murmur.
So it's not just one sound, it's a sequence of sounds that create a distinct pattern.
Precisely. And those sounds, combined with the patient's symptoms and medical history, can help us paint a clear picture of what's going on.
Now, how do we approach treatment for mitral stenosis?
Well, it depends on the severity of the stenosis and the patient's symptoms. In some cases, medications to manage symptoms like heart rate or fluid buildup might be sufficient.
But for more severe cases, I'm guessing we need to look at interventions.
You're right. One option is percutaneous mitral balloon valvuloplasty, or PMBV.
PMBV, that rings a bell. It's a minimally invasive procedure where a balloon is used to widen the narrowed valve, right?
Exactly. It's like inflating a tiny balloon inside the valve to stretch it open.
That's pretty amazing when you think about it. And if TMBV isn't suitable, or if the stenosis is extremely severe, we have the option of mitral valve replacement.
You got it. Now let's move on to mitral regurgitation, the counterpart to mitral stenosis in this case. Instead of being too narrow, the mitral valve doesn't close properly, allowing blood to flow backward from the left ventricle into the left atrium during systole.
Okay, so we've got that backflow issue. Again, similar to what we saw with aortic regurgitation. What are the consequences of this backward flow in the mitral valve?
Well, just like with any type of valve regurgitation, that backflow creates a volume overload. In this case, it affects both the left atrium and the left ventricle.
So both chambers have to work harder to compensate for that leaky valve.
Precisely, and over time, that extra workload can lead to dilation and weakening of both chambers, potentially leading to heart failure.
Now, I remember learning that mitral regurgitation can be primary or secondary. What's the distinction there?
That's a great question. Primary mitral regurgitation means the problem lies within the mitral valve itself. It could be due to issues with the valve leaflets, those flaps of tissue that open and close, or problems with the chordae tendineae, the tiny cords that anchor the leaflets to the heart muscle.
So it's like a structural problem within the valve itself.
Exactly. Secondary mitral regurgitation, on the other hand, is caused by dysfunction of the left ventricle. Think of it this way. If the left ventricle isn't pumping efficiently, it can create changes in the geometry of the heart that affect the mitral valve, leading to regurgitation.
So it's not the valve itself that's faulty. It's a consequence of a problem elsewhere in the heart.
Precisely. And that's why it's so important to understand the underlying cause of mitral regurgitation, as it will guide our treatment strategy.
Now, to diagnose and assess the severity of mitral regurgitation, our trusty friend echocardiography comes into play again, right?
Absolutely. Echocardiography allows us to visualize the valve, see the backflow, and measure how much blood is leaking.
And I'm guessing the severity of regurgitation will influence the treatment options.
You're right. For mild cases, we might just monitor the patient and manage any underlying conditions. But for more severe cases, we have several interventions at our disposal.
Okay, let's talk about those interventions. What are our options for treating severe mitral regurgitation?
Well, one option is surgical repair of the mitral valve. This involves fixing the damaged parts of the valve, such as repairing the leaflets or replacing the chordae tendineae.
So it's like a delicate surgery to restore the valve's proper function.
Exactly. And in some cases, mitral valve replacement might be necessary, especially if the valve is severely damaged or repair isn't feasible.
And I remember learning about a less invasive procedure called the MitraClip.
That's right. The MitraClip is a transcatheter procedure where a small clip is used to pinch a portion of the mitral valve leaflets together, reducing the backflow. It's a good option for patients who are at high risk for traditional surgery.
So we've got surgical repair valve replacement and the Mintra clip, all tools in our toolbox to tackle mitral regurgitation.
Now, before we move on, let's touch on another valve condition, tricuspid regurgitation. It's less commonly tested on the MCCQE compared to aortic and mitral valve issues, but it's still important to understand.
Okay, bring on the tricuspid valve. What do we need to know about tricuspid regurgitation?
Well, unlike aortic and mitral regurgitation, which can be caused by a variety of factors, tricuspid regurgitation is often what we call secondary.
Secondary, what does that mean in this context?
It means it's usually a consequence of problems happening elsewhere in the heart rather than being a primary issue with the tricuspid valve itself.
Interesting. So it's like a domino effect where problems in other parts of the heart eventually affect the tricuspid valve.
Exactly. Conditions like pulmonary hypertension, heart failure, or atrial fibrillation can all put extra strain on the right side of the heart where the tricuspid valve resides.
Right, because the right side of the heart is responsible for pumping blood to the lungs. So if there's increased pressure in the pulmonary arteries, for example, the right ventricle has to work harder to push blood through.
Precisely, and all that extra work can cause the tricuspid valve to become stretched and leaky, leading to tricuspid regurgitation.
So it's like the tricuspid valve is a victim of circumstance, bearing the brunt of problems happening elsewhere in the heart.
In a way, yes. Now, when it comes to managing tricuspid regurgitation, the first step is to address the underlying cause.
Okay, so if it's pulmonary hypertension, we treat the pulmonary hypertension. If it's heart failure, we optimize heart failure medications.
Exactly. The goal is to reduce the strain on the right side of the heart, which can often improve the tricuspid regurgitation as well.
But what if treating the underlying cause isn't enough? Are there other options for addressing the tricuspid regurgitation itself?
In some cases, yes, if the regurgitation is severe and causing significant symptoms, surgery might be considered.
What would that involve replacing the tricuspid valve?
It could, but sometimes repairing the valve is an option. There's also a procedure called tricuspid annuloplasty, which involves tightening the ring of tissue around the valve called the annulus.
So it's like reinforcing the valve to prevent it from leaking as much.
Exactly. Now, this brings up an interesting point about the overall management of valvular heart disease. It often involves a multidisciplinary team of specialists working together.
Okay, teamwork makes the dream work. Who are the key players on this heart valve dream team?
Well, you've got clinical cardiologists who are the experts in diagnosing and managing heart conditions.
They're like the quarterbacks calling the plays and coordinating care.
Exactly. And then you've got advanced cardiac imaging specialists who are the masters of echocardiography and other imaging techniques. They're like the detectives using their tools to gather crucial information about the heart.
And then, depending on the specific situation, we might also bring in interventional cardiologists who perform procedures like TAVR and PMBV, and cardiac surgeons who specialize in surgical valve repair and replacement.
Right. They're like the skilled technicians using their expertise to fix the problems.
And let's not forget about advanced heart failure specialists. They're crucial when valvular heart disease leads to heart failure.
Absolutely. They're like the support system providing expert care for patients with more complex needs. So you can see it's a truly collaborative effort with each specialist bringing their unique skills to the table.
That makes a lot of sense. It's like a well-oiled machine with everyone working together to provide the best possible care. Now, we've talked a lot about valve replacement, but I'm curious about those prosthetic valves themselves. Are they a permanent fix?
They're designed to last a long time, but they do require ongoing monitoring and sometimes further intervention.
Okay, so it's not just get a new valve and you're good to go. There's more to it than that.
Right. For example, one thing that can happen is prosthetic valve dysfunction. Basically, the valve doesn't work the way it should.
How do you even know if that's happening? What are the signs?
Well, it can mimic the symptoms of the original valve problem. So you might see things like shortness of breath fatigue or swelling.
So it's almost like going back to square one.
In a way, yes. But the good news is that we have ways to diagnose and manage prosthetic valve dysfunction.
Like what more echocardiograms?
Echocardiography is definitely a key tool, but sometimes a transesophageal echocardiogram, or TE, is needed. It provides a clearer view of the prosthetic valve than a standard echocardiogram.
And I'm guessing other imaging techniques like CT scans or even fluoroscopy might be helpful in some cases.
You're on the right track. Those imaging tools can help pinpoint the problem and guide treatment.
So what are the treatment options if a prosthetic valve isn't functioning properly? Is it another valve replacement?
It could be, but sometimes less invasive procedures are possible. For example, if there's a blood clot interfering with the valve medications to break down the clot, might be used.
Interesting. So it's not always a surgical fix.
Nope. Now, another important aspect of prosthetic valve care is regular surveillance.
Surveillance, like keeping an eye on things.
Exactly. Regular checkups and imaging tests help ensure the valve is functioning properly and catch any potential problems early on.
I'm starting to see a theme here. Early detection is key.
It really is, and that applies to all aspects of valvular heart disease, not just prosthetic valves.
Speaking of things we need to keep an eye on, let's talk about infective endocarditis. I remember this being a pretty serious condition.
It is infective. Endocarditis is an infection of the heart valves, and it can be life-threatening if not treated promptly.
So it's not just a minor inconvenience, it's a big deal what causes infective endocarditis.
Bacteria are the usual culprits. They can enter the bloodstream through various routes, such as dental procedures, IV drug use, or even skin infections.
And I'm guessing if someone has a damaged heart valve or a prosthetic valve, it's easier for those bacteria to take hold and cause trouble.
You're absolutely right. Those valves provide a perfect breeding ground for bacteria to multiply and create those pesky vegetations.
Vegetations, what are those?
They're basically clumps of bacteria and other debris that form on the valve. Imagine barnacles clinging to a ship's hull. These vegetations can interfere with the valve's function and even break off, causing emboli.
Emboli. Oh no, that sounds scary.
Those emboli can travel through the bloodstream and get lodged in other parts of the body, causing strokes, heart attacks, or other serious problems.
Okay, this infective endocarditis is sounding more and more worrisome. How do we even diagnose it?
Well, it often starts with a clinical suspicion based on the patient's symptoms, which can be quite varied.
Like what kinds of symptoms? Fever, chills?
Those are classic signs of infection. So yes, you might see those, but you can also see things like fatigue, weight loss, night sweats, or even heart murmurs.
Wow, that's a pretty broad range of symptoms.
It is, and to make things even trickier, the presentation can be subtle, especially in the early stages.
So it's not always a slam dunk diagnosis. What else do we use besides symptoms to diagnose infective endocarditis?
Blood cultures are crucial. They can help identify the specific bacteria causing the infection, which is important for guiding antibiotic treatment.
So it's like detective work, figuring out who the culprit is, and what about imaging? Does that play a role?
Absolutely. Echocardiography is our go-to imaging tool for visualizing the heart valves and looking for those telltale vegetations.
And if echocardiography isn't clear enough, there's always T to provide a more detailed view.
You got it now. Once infective endocarditis is diagnosed, treatment usually involves a prolonged course of intravenous antibiotics.
Okay, so we're talking weeks of IV antibiotics.
Often, yes, and in some cases, surgery might be necessary to repair or replace the damaged valve.
What factors would make surgery necessary?
Well, if the infection is severe, causing heart failure or other complications, surgery might be the best option also. If the valve is severely damaged, or if antibiotic treatment alone isn't effective, surgery might be recommended.
It sounds like infective endocarditis is a serious condition that requires a multi-pronged approach to treatment.
It does, and that's why early detection and prevention are so crucial.
Speaking of prevention, are there things people can do to lower their risk of developing infective endocarditis?
Absolutely. Good oral hygiene is key, as is avoiding unnecessary procedures that could introduce bacteria into the bloodstream.
So brush those teeth, folks, and if you have any cuts or sores, keep them clean and covered to prevent infection.
Great advice. And if you're at high risk for infective endocarditis, talk to your doctor about the possibility of taking antibiotics before certain dental or medical procedures.
Okay, great tips. Now let's switch gears and talk about another unique situation: valvular heart disease in pregnant women.
This can be a tricky area, as pregnancy places extra demands on the heart.
Right, because the body has to work harder to supply blood to both the mother and the growing baby.
Exactly. So if a woman already has valvular heart disease, pregnancy can exacerbate the condition.
Now, what kinds of challenges might pregnant women with valvular heart disease face?
Well, they're at increased risk of complications like heart failure, arrhythmias, and even premature labor.
That's a lot to deal with. How is valvular heart disease managed during pregnancy?
It depends on the severity of the disease and the specific valve affected, but generally the goal is to optimize the mother's health while also ensuring a safe pregnancy and delivery.
So it's a delicate balancing act.
It is. In some cases, medication might be needed to control blood pressure, heart rate, or other symptoms. And in more severe cases, procedures like balloon valvuloplasty or even valve surgery might be considered.
Wow, that's intense. I'm guessing these decisions aren't made lightly.
They're not. It's a multidisciplinary effort involving cardiologists, obstetricians, and often other specialists.
So it's like a super team of experts coming together to create the best plan for both mom and baby.
Exactly. Now, another thing to consider is the type of prosthetic valve if a woman needs a valve replacement.
Okay, I'm curious, what's the difference between the types of prosthetic valves in this situation?
Well, mechanical valves are durable, but they require lifelong anticoagulation, which can pose risks during pregnancy.
Right, because blood thinners can increase the risk of bleeding complications.
Exactly. Bioprosthetic valves, on the other hand, don't require lifelong anticoagulation, but they're not as durable.
So it's a trade-off durability versus anticoagulation risks. Tough decision.
It is, and that's why shared decision-making between the patient and her healthcare team is so important.
Well said. Okay, I feel like we've covered a ton of ground when it comes to valvular heart disease. Any final pearls of wisdom before we wrap up this deep dive?
Just a reminder that we've only scratched the surface here. Each of these valve conditions has its own nuances and complexities.
True. And the guidelines and recommendations are constantly evolving as new research emerges.
Exactly. So always stay curious, keep learning, and don't be afraid to dive deeper into the topics that pique your interest.
Couldn't agree more. So are you ready to move on to another condition?
Ready when you are.
Okay, so we've explored this whole range of valvular heart conditions, from the super serious, the more manageable ones.
Yeah,
But there's one more we need to cover
we do.
that often trips students up.
It does.
Mitral valve prolapse, or MVP.
Ah, yes, MVP. It's a fascinating condition
It is.
that often gets a bad rap.
Okay.
Think of it as a bit of a heart valve rebel.
A heart valve rebel.
Not always following the rules.
I like that analogy.
Yeah.
Okay, but what exactly is going on with the mitral valve in MVP?
So picture the mitral valve leaflets like these tiny swinging doors between the left atrium and the left ventricle.
Okay.
In MVP, one or both of these leaflets bulge back into the left atrium during systole, which is when the heart is contracting.
So instead of closing smoothly, the leaflets kind of flop back into the atrium.
Exactly. And that bulging or prolapsing
Collapsing.
can create a clicking sound as the leaflets snap back into place.
Okay.
It's often described as a mid-systolic click, meaning it happens in the middle of the heart's contraction.
So that's the click,
Oh.
but there's also a murmur associated with MVP.
There is.
What's causing that?
The murmur is like a whooshing sound that follows the click.
Okay.
And it's caused by the potential for blood to leak back into the left atrium because of the prolapse.
So the leaflets are creating a bit of turbulence as they try to close,
Exactly.
leading to that whooshing murmur sound.
Yeah, almost like a little heart whisper,
A heart whisper.
telling us something's not quite right.
Okay. Yeah.
Now, the good news is
Good. Yeah.
MVP is actually quite common.
It is.
And in most cases, it's completely benign.
That is good news.
So a lot of people have it.
Yeah.
And they live perfectly normal lives.
Without even realizing it.
Without even knowing it.
Okay, that's reassuring to hear.
But of course, like any heart condition, there are instances where it can be more serious.
So when should we be concerned about MVP?
In some cases, MVP can lead to complications like mitral regurgitation arrhythmias or even endocarditis.
Oh, so those are some serious complications.
Yeah, remember, those leaflets aren't closing as tightly as they should,
Right.
which can create opportunities for problems.
So how do we figure out if someone's MVP is more on the benign side or more on the concerning side?
Our go-to tool is echocardiography.
Of course, echocardiography.
It allows us to see those valve leaflets in action and visualize that characteristic prolapse.
And I'm guessing those auscultatory findings, the click murmur combination that we talked about,
Yes,
can also play a role in raising our suspicions.
absolutely. Those sounds, especially when heard together, are a classic sign of MVP and often prompt further investigation with an echo.
So let's say we've diagnosed someone with MVP.
Okay.
What's the next step? Does everyone need treatment?
Not necessarily. If someone is asymptomatic, meaning they have no symptoms, we often take a watch and wait approach.
Okay.
We monitor them regularly with echocardiograms to make sure things aren't progressing.
So we're keeping an eye on that heart valve rebel,
We are.
making sure it's not causing any trouble.
Exactly. But if symptoms do develop,
Yeah.
or if complications arise, we have options.
Okay, so what are our options for managing symptomatic or complicated MVP?
Well, medications like beta blockers can help manage symptoms like palpitations or chest pain.
Okay.
These medications work by helping slow down the heart rate and reduce the force of contractions, which lessens the strain on the valve.
And for more severe cases, would we ever consider surgical intervention like we discussed for the other valve conditions?
Yes, in some cases, surgical repair or replacement of the mitral valve might be necessary.
Mhm.
This is usually reserved for people who have severe mitral regurgitation or other complications from their MVP.
Okay, so there's a whole range of management strategies for MVP,
There is.
depending on the individual situation. Well, this has been an incredible deep dive
It has.
into the world of valvular heart disease.
I agree.
I feel like I've learned so much, and I'm sure our listeners have too.
Me too.
So,
It's been my pleasure.
the pleasure was all ours.
I always say the more you understand about the heart, the more you appreciate its incredible complexity and resilience.
Absolutely. And remember, everyone, this is just the beginning of your journey into understanding valvular heart disease.
It is.
So use this deep dive as a foundation
Yes.
and keep exploring. Dive into your textbooks, read research articles, and discuss these concepts with your classmates and your professors.
Good advice.
The key to mastering any medical topic, especially for the MCCQE, is not just about memorizing facts. It's about developing a deeper understanding of the concepts and being able to apply that knowledge to real-world clinical scenarios.
And never underestimate the power of practice.
Yes, practice, practice, practice.
Work through those practice questions,
Yeah.
challenge yourself with those case studies, and don't be afraid to seek out guidance when you need it. We're here to support you every step of the way.
Thanks for joining us on this deep dive into valvular heart disease. We'll see you next time for another exciting exploration of high-yield MCCQE topics.
Best of luck on your MCCQE journey, everyone. You got this.